Welcome to the show. Hi, I'm Randy Jeffers, and we are live from the entertainment capital of the world, Las Vegas, Nevada. Well, we have a really special show for you today. We have with us Dr. Jay Mead, medical doctor. And Dr. Jay, it's great to have you here. Welcome, and I can't wait to hear all the wonderful things about you. You have just an incredible thread of success from everything I've heard about you, and lots of experience in all kinds of things. So if you would just sort of put your modesty in your back pocket and start us off and tell us a little bit about yourself.
Well, thank you. I really appreciate being here, Randy. It's a special opportunity, I feel. Tell you a little bit about myself. I'm a pathologist by training and got involved in that aspect of medicine for a number of years.
Now, for those of us that are sort of novices that may not know what that is, can you explain what pathology is?
You know, what I do when someone asks me that question, I usually take them to a TV show. There was a pathologist, and I'm blanking on the show's name.
Was Jack Klugman? Did he play that?
Yeah, I think he did. What was the name of the show? Was
oh man, it's been a long time.
Yeah. Well, anyway,
you have to be a certain age to even remember
that's
that.
right. In my age, my memory isn't as good as it used to be, obviously. But pathologists are doctors. We're using the background, so we're in the laboratories. We're giving the doctors information that they use to treat patients.
Okay.
Also, the part of pathology that distinguishes us from others is that we manage the tissue. So when something is removed from a person and it goes to the laboratory and we want to determine the nature of that tissue, and it's usually something that's pathology or pathological, and then we look at it through microscopes and determine what it is. So, you know, unfortunately, part of the business is diagnosing cancer, and we're the ones who make that determination when the tissue comes to us.
Oh, really? So if someone has, you're the one that decides if they have cancer or not.
That's correct. Right.
Wow.
So, you know, all the studies are done, and and everybody suspects it, but when the final decision comes to what you see under the microscope. And so we do a lot of microscope work in our training, and in order to be certified to do that. And then another aspect is that we do the autopsies. And the TV show I was going to mention is about a forensic pathologist, and in kind of like Dick Tracy or
detectives. You're a detective.
We are a detective in the sense that we try to determine the cause of death.
Yeah.
And if there's been a homicide, we have to sort through that. Now, and that's a specialty within the specialty. That's called forensic pathology.
Now, are you a forensic pathologist as well?
No, I'm not certified in that.
Okay.
I did, however, work in a group where we did have a forensic pathologist, and so when I was on call and something would happen and the forensic pathologist wasn't available, I would have to step in until he could take over the case.
I see.
So that's part of pathology that's not the most pleasant.
Yeah, I was going to ask you about that. What made you decide you wanted to be a pathologist?
Well,
I mean, you're dealing with dead bodies a lot of times, and you're dealing with tissues that come off of people and some pretty nasty things, right?
Yeah, well, when you first go into it, you don't. I don't think we understood that when you're in medical school. And when I was in medical school, I did very well in the courses I took, and there was a professor, kind of a mentor type, and he sort of took me under his wing and told me I'd make a good pathologist, and so I did.
Yeah.
But to take the story further, 20 years ago, I left that arena and I started seeing patients.
Oh.
And so I often tell audiences when I'm speaking, and I speak on different topics to different conferences, and we'll maybe get into that to some extent. But I would remark that I'm a pathologist who sees warm patients.
Yeah.
So I went from
cold to warm.
Went from cold to warm, and 20 years ago, as I mentioned, I started that, and it has just been the most amazing journey that I could have ever taken. And so I see patients still, and I do more complementary, alternative, holistic type medicine now. Because what I discovered 20 years ago was that in my medical school training, my allopathic medical school training, and I went to medical school at the University of California, San Francisco, and didn't really teach me or make me aware, make classmates aware of the alternatives to the conventional path of medicine.
Yeah, I've heard that so many times.
Yeah, it's very common. Unfortunately, the pharmaceutical industry basically controls our medical education.
Yeah.
And so what I learned, and actually this, I'll take this back to why I went into pathology. I was basically being trained to write prescriptions. You know, you learn all the biochemistry and physiology and anatomy and all that, but it comes down to, when you see the patient, what drug am I going to give that patient for the symptoms they walk in for? And the patient expects a drug. Our culture is set up to where that happens.
Treating the symptoms.
Right, and the patient knows, and these studies have been done, when the prescription's written, the visit's over.
Right.
And the doctor, within very few seconds, I believe it was a Harvard study that within, I forget the exact 15, 30 seconds, the doc knows what he or she's going to write for.
Yeah.
And when the prescription pad comes out, patient's happy and and then the visit's over, and then the prescription's handed to the patient, and then that's the end of the visit. And I didn't like that part of medicine. As I was as a student, it wasn't that interesting to me, but the study of disease was interesting to me, and that's what pathology is basically. The word speaks for itself. It's the study of disease.
You know, you mentioned that the doctor knows within 15, 20 seconds what he's going to do. So there's an obligatory amount of time that he has to spend just to make the patient feel good, I imagine, right?
Right.
And is that sort of set? Do doctors know that? Or do they just sort of depend on the patient?
we evolve into it.
Yeah.
And when you have to see 30 patients a day, and your time is very critical, and the patient knows it's going to be a pretty short visit anyway.
Yeah.
And as opposed to the way I practice now, initial visit is an hour and a half.
Wow.
Because it's important to understand the patient, understand their lifestyle, their nutritional habits, and their whole history, and their family history, and get into their their well-being. What kind of stressors do they have in their lives? What have they been exposed to in terms of environmental toxins? And there's so many of those around, and those are often ignored in allopathic medicine. And so it takes an hour and a half to really get into the patient, understand where you want to go and what you want to do, and not involve a pharmaceutical.
Yeah.
Start looking at ways to improve their health. I mean, nutrition is key to our well-being.
We are what we eat, right?
Exactly.
That old saying is really
we
true.
are what we eat. Absolutely.
How about the old saying, the apple a day keeps the doctor away? Is that true?
Well, and it would be, an apple a day would be better than a can of Pepsi, I would say.
Or French fries.
Can of French fries. Yeah. So that that changes the whole perspective of medicine when you can spend an hour and a half, but you obviously can't see patients through the system that is only going to pay you enough to keep your lights on if you have to see 30, 40 patients a day.
Yeah.
And that's the sad part about our system.
Well, bless you for that. I mean, you're in the minority, though, right? I mean, there aren't many doctors that do that. It seems like they want to go for the dollars, and they need to see a lot of people, right?
Right, to do that.
Yeah.
Well, it's the type of medicine that I have to practice just to keep my conscience clear.
Yeah. Now, in that field of pathology, are there a number of fields within the field?
Yes, there are.
Yeah.
Like all the specialties in medicine, there's subspecialization. Like there are hematologists, pathologists. There are dermatology specializing pathologists, neuropathology, forensics. I've mentioned, and actually within some subspecialties, there are specialists within that. So, for example, for leukemias and lymphomas, within someone who specializes in hematopathology, they can be subspecialized into various types of lymphomas, which are now becoming more complicated to understand histologically and through various staining methods and DNA testing that we can do now, and you can subcategorize various cancers. So
Now, what's your area? What's the main kind of area that you feel most comfortable in?
Well, actually, I specialized in blood banking, so I have a subspecialty certification in blood banking, which led me to actually work with the American Red Cross for 10 years. I was the chief medical officer in Portland, Oregon, at the Pacific Northwest region of the American Red Cross for 10 years.
Now, that has to be fascinating. Tell us about that. So, now, the American Red Cross, they're, that's huge, right? It's a huge international organization.
It is.
How many places do they have?
Well, there's actually two parts to the American Red Cross. There's the rescue volunteer part, and when these disasters occur, that part of the Red Cross gets involved, and within the Red Cross, there's the blood centers that do the blood collecting, processing, and distribution to hospitals and clinics and so forth. And so when a disaster strikes, the volunteer part of the Red Cross goes into action, and that usually doesn't affect the blood center unless it's within that region. And there are various regions of the Red Cross in several blood centers. I don't know the exact number now. There were 15 or 20 American Red Cross centers when I was involved.
Worldwide or in the U.S.?
No, just in the U.S.
Oh, in the US.
The blood services part of the Red Cross is limited to the U.S., but they cover a large portion of the U.S. And so the blood center in the region where there is a disaster, of course, then they're going to get very active, and they're going to want to bring in a lot of blood donors and ramp up because there's going to be a need.
Sure.
If there are injuries, for example, what happened in Las Vegas on October the 1st.
Yeah.
The blood center here had to get really active and quick.
I know the news was talking about asking people to go donate blood.
Right.
So when you go donate blood, they take the blood out of your arm, and then what happens to it next?
Well, it's an interesting process. It's complex in that the unit of blood that one donates can be broken down into several components. One component would be the red blood cells, and that's what you generally need for surgery and trauma, and that sort of thing. They can also take the platelets out of a unit of blood, and the platelets are the little clotting factors that circulate in our blood, and they're critical for blood clotting in individuals who don't have enough of them. For example, cancer patients who are under chemotherapy, their bone marrow doesn't work well and make the platelets, and so they're going to need that component.
So you would give them the platelets, not just the blood.
Right. You can actually concentrate
So
the
you isolate
platelets and
them
give
out.
them. Yes, you can. You can do that. And then there's the liquid portion of blood we call plasma, and that's separated out. And so now you at least have three components. You have the platelets, you have the red cells, platelets, and the plasma.
How about the white cells? Is that the plasma?
The white cells are actually mixed in with the platelets.
Okay.
But generally, they don't separate out the white cells per se. They try to separate the platelets from the white cells. If you let me start over. If you spun a unit of blood, you would have the dark
Now
red
that means
cells.
you put it in a centrifuge.
Put it in a centrifuge and spin it at high speed,
Okay.
and you'd bring down the heavier components. That would be the red cells would be the heaviest, and then above that there's a really thin line. It's called the buffy coat,
Yeah.
And it's very thin. You have to look at it closely to see it. In that buffy coat are the platelets and the white cells. And the platelets we've talked about. Now, the white cells per se don't necessarily have a function because they're starting to already lose their function. The platelets maintain their function, and so the white cells just kind of come along.
Oh,
But
yeah.
we want to concentrate the platelets when we can. So then you have the plasma, and that can be given fresh, or you can freeze it, and that can be used actually years later if you freeze it in liquid nitrogen, which they do sometimes.
Sure.
And so that's, those are the basic three components. Now you can get more elaborate if you take the plasma, and then you can separate out clotting factors from the plasma. Like
Wow.
we've heard of hemophilia, for
Uh-huh.
example. You can concentrate factor VIII out of the plasma, and so now you can have a factor VIII component too that you can now give to those individuals. So they're getting more and more sophisticated about breaking down components.
Now, one of the hot things that you hear a lot about now is something called PRP, and that stands for platelet-rich plasma, right?
Mm-hmm.
And tell us about that, because that sort of goes right along with what you were talking about.
Well, it does. Now that's not done in the blood center per se. Well, actually, the platelet component that you would give to someone who needed platelets is platelet-rich plasma. Because that's what they've done. They basically concentrated.
Now, can you use somebody else's plasma, platelet-rich plasma, or do you have to use your own?
Well, it's preferable to use your own if you're using it for other reasons than for the clotting component.
Oh, okay.
So platelet-rich plasma that you're referring to is generally made from an individual. So it's autologous. It comes from that individual
yourself,
versus homologous, which would come from someone else. So, and that's going to be injected back into that person. So you take the blood. Now you don't take a whole unit of blood from a person to make this. You might take 50 milliliters and spin that down, and then take that little buffy coat layer that I mentioned, and mix that into a little bit of the plasma on top. Now you have platelet-rich plasma. And the benefit there, it's not so much it's not for the clotting benefit of the platelets, which you would use if you were needing a large volume of platelets for the cancer patient, for example. But in the platelet component, not just the clotting aspect of the platelets we're looking for, but there are growth factors that will help heal injured tissue. And so that's where platelet-rich plasma is used mainly now. You can inject it, it repairs because of it. It has the growth factors, a number of them, and some of them actually stimulate stem cell migration to the injured part of the body where they're injected.
They've been doing, I have a doctor friend that has been using PRP for knees, for instance.
Mm-hmm.
And, that was a terrible surgery not very many years ago, right? Big scars. And so now I think he just injects, using a needle, and injects it right into the spot, and it starts healing and doing these miraculous things that nobody could ever thought possible a few years ago.
Miraculous is the word for this.
Yeah.
I attended a conference recently where an orthopedic surgeon was injecting PRP right into a knee where there was very little cartilage, and there were, the next option for the patient was surgery. But rather than do that, they were experimenting with platelet-rich plasma, and they were also injecting stem cells at the same time, and they were regrowing cartilage, preventing knee surgery. Which you can take that anywhere. If you can repair cartilage in a knee, you could repair it in your hip.
Wow.
So those hip surgeries may be changing. The frequency of that hip replacement surgery may be changing. The knee replacement surgery hopefully will change. That's a very complicated surgery, and the recovery from that is very difficult and time consuming and painful. They're using PRP for almost any injury, any joint. I have a colleague who actually used it to repair the tip of a thumb that had been severely damaged. And in fact, about two-thirds of the thumb, the skin of the thumb, had been taken off. I believe it was a knife accident. And platelet-rich plasma was used on a regular basis, just into that wound, and completely healed the thumb. It was remarkable. He was showing me the photos of it. So the healing power of platelet-rich plasma is unlimited. We continue to explore it.
Now, you mentioned stem cells. Now, that's something you're hearing a lot about now. And do stem cells, first of all, maybe you could explain to us what it is, and I guess it seems to me that maybe it takes PRP to another level. Would that be accurate?
Well, there would be a synergy between
Okay.
the stem cells and PRP. I mentioned that PRP will cause migration of stem cells to the area. So let's start with just talking about stem cells.
Yeah.
We all have them. Even at my age, I have some, but I don't have as many as a baby, a newborn. But those are the cells that will go to wherever they're needed and will change from being undifferentiated, with the potential to do whatever it's required of them, to differentiating into that tissue, like the cartilage I mentioned in the knee.
Mm-hmm.
So these cells are undifferentiated. They're the basic cells. We call them totipotent cells. They can do whatever the body needs them to do. They're the healing component of our body, and they can whatever. If you get enough of them, and in the right milieu or in platelet-rich plasma, they're ready to go. They have everything they need, and the repair can be phenomenal. As I saw with the knees that the orthopedic surgeon showed. He also showed, which was really startling, that a cruciate ligament tear in a knee, the anterior cruciate ligament, was almost tore. It was just hanging by a thread, and they did the PRP and stem cells and repaired the cruciate ligament without any surgery. I mean, and that's incredible. Think about the
what a
benefit
miracle
of
that is.
right? And PRP is now being used for wrinkles and skin. Just general skin health. There are procedures cosmetic procedures where platelet-rich plasma.
You hear about the vampire, right?
Vampire facelift.
Yeah.
It works. It's remarkable without cutting. No surgeries needed there. So the body, I think the bottom line is the body has the potential to heal.
Uh-huh.
It has the potential to be more youthful, given the right support. In this case, get platelet-rich plasma to the area. That will cause healing and stem cell migration and repair.
So knowing all the things that you know from your perspective as being a pathologist, what do you think the future holds? You hear stories about. I heard a story of a gerontologist in the UK that made a statement that the first person to live to be 1,000 may already have been born. Is that really possible, you think?
Wow, that's a stretch.
That's a stretch.
When you think about the average life expectancy is about 85 years now.
Yeah. But
And
can stem cells extend life, you think?
Well, it can certainly make us healthier and
Yeah.
give us more quality of life. And I would imagine, I think you can easily project that it will extend life. If you can heal, heart disease and brain disease, like for example, Alzheimer's disease and those sorts of things, those all have potential to be healed. And I don't believe they're all fatal chronic diseases. I think with the right approach, including perhaps now stem cells, we'll be able to heal those things. What we do know about the human body is that it's programmed to die.
Yeah.
In fact, you and I sitting here, 200 years ago, we'd have been in the ground a long time ago. You know,
Right.
So here we are, and why? Well, you know, we have sanitation, and you know, we eat well, and for those of us who are concerned about that part of our lives, you know, we change our diet. You know, we use supplements as we need to. We can use natural hormones to continue a youthful lifestyle and help our body last longer. But there's one component that so far we haven't been able to change, and that is the growth hormone component. So our brains, over time, shut off our growth hormone production. It's a program. It's like a software glitch.
Really?
I would like to, but it's the way it is. You know, our species, you know, our purpose, if you will, is to procreate. Once we've done that, we're not all that useful.
Not as
But,
useful,
you know,
yeah.
like at my age, I'm not doing any of that, but I'm still here and I'm vital, and so I want to contribute. But the growth hormone level starts to decline at about age 30, and
At 30?
yeah, and you see that with the athletes. You know, that's when they start, you know, looking for some help.
Yeah.
And a lot of them, by the way, use PRP now, particularly in
I've heard
injuries.
that.
And they use oxidative therapy. Some of them use hyperbaric chambers, and all of that. And we can talk about that if we get around to it. But you know, as our growth hormone drops, our bodies deteriorate. And as growth hormone drops, our stem cell population drops as well. So we thought we had the panacea about, that paper came out about 15 years ago, where they gave growth hormones, injected growth hormone. It can be genetically engineered. It is genetically engineered, and it's available. Children who have stunted growth, I mean, growth hormone will change their stature. So it's remarkable what it'll do. But there's a study that was in the New England Journal where they used growth hormone in older men, and it was amazing. Their blood sugar levels dropped, their testosterone levels increased, their lifestyle increased. They were, you know, their quality of life was improved. And so we thought, well, now we're on to something here.
Now, what you're talking about is what they call HGH?
Yes, HGH,
Okay, HGH, okay.
human growth hormone, HGH. Unfortunately, it's not available to everybody, and there has been a movement actually by the federal government to suppress the use of it. And so if it's you know, using it to extend life or become more vital and youthful is not an indication of growth hormone. So it's not available at that level, and that's okay, because now we other things are coming into the picture now. Yeah, like PRP and stem cells.
Yeah.
Stem cell might, well, you know, stem cell has the potential to even be more potent than growth hormone potentially. We'll have to see.
Yeah, one of our mutual friends, Dr. Bill, saying that I think is the smartest guy in the world. I always tease him about being the smartest guy, but you know,
You're definitely a smart guy.
he made a statement that he thinks within 5, 6, 7, 10 years that pretty much every medical condition, one way or another, for the most part, is going to be treated with stem cells, other than headaches and things like that. But that's an amazing statement when you think about it, you know. And I mean, this is sort of the future, isn't it, of medicine?
Yeah, I think that's the way it's going to go, and he may not be far off. He may be it may take a little longer than that, but you know, who's to say? But he may be exactly right. The interest in stem cells is definitely increasing exponentially.
So what's going to happen to our society? You know, if stem cells can increase longevity, you know, there's only so much resources we have here.
Yeah.
I mean, what's going to happen? Everybody can't live, you know, to be 1,000 years old, right? I mean, And I guess maybe one of the saving graces of all this, it's sort of sad, but insurance doesn't cover some of these treatments, right?
None of them that I'm aware
Yeah.
of, except for growth hormone, HGH, and with children. And I have a patient who gets it through Medicare, but she had a damaged pituitary gland, and we could prove that. But for the most part,
So it's-
anti-aging medicine is not available.
So it's those of means are the ones that will live
That's
the longest, and
Yeah, it's unfortunate.
yeah.
You know, think of the political ramifications. If we just all lived to be 100,
Yeah.
you know, not 1,000. I mean,
No Social Security.
Social
I mean,
Security
beyond.
would collapse, and
It's going to collapse anyway.
yeah,
probably.
and
Yeah.
and that's partially because we're living longer just by the other things we've done.
Yeah.
So we have an aging population. Oh, and then there was the Second World War. Now we have the baby boomers.
Yeah.
And I'm one of those. Hitting the system where we're going to need more medical attention. And so it's I don't know what would happen. It's interesting. But there are forces that don't want to see that happen.
Yeah.
Right?
Well, I'm sure a lot
you
of
know,
politics, huh?
Yeah, there would be. I mean, if you're thinking about the future of medicine, we're not going to have enough doctors. We're not going to. I mean, it's going to be a stretch to be able to manage all of that.
It's what a fascinating field. This is a great time to be involved in medicine, isn't it?
Well, I think so.
Yeah.
I think so. Particularly at my age, with this with stem cells coming along, I want to see what they can do for me.
Better than the past.
Yeah.
Maybe not as good as 10 years from now, though. It might even be better.
Yes.
Yeah.
Well, we continue to improve, and one of the things that's going to perhaps change. I was thinking about this the other day. To be able to culture stem cells, and from what I understand, and I'm limited in this area of knowledge, culturing stem cells and getting them to grow in sufficient numbers, it's difficult. They're
Yeah.
difficult to culture. They're available though through we all make them, so we can enhance what we produce. And oxidative therapy will help that out, by the way. But the source for stem cells is our critical step to get those, to find a source of stem cells that we can either culture or find in sufficient volume to treat these conditions we're talking about. I think that's going to be the rate limiting step right now, as I understand it.
So there's a lot of ways to get stem cells, and as I understand it, one of the really popular ways, good ways, is to get them from umbilical cords.
Yes.
So you can get cord blood stem cells, right?
And that goes back to our earlier discussion about where do you get the best and healthiest stem cells. Well, the cord blood is the perfect source for it.
Yeah.
Yeah, that's.
Now that in and of itself is a little, or was controversial, because it wasn't many years ago when they were doing some experimentation. They were getting the stem cells from the embryo, and of course, that's a very hot topic, and it's outlawed. Thank goodness, in my view. But yeah, you can't get it from a baby, but you can get it from the cord, and the cord is just thrown away anyway.
That's right.
It's nothing of value. So
And it goes to the pathologist.
it goes. Yeah, that's right.
And it's put in formalin, and then it's damaged for that purpose. But if you can get a placenta fresh, and get the blood, and placenta has a lot of blood in it, actually. We were looking at that when I was with the Red Cross 20 years ago. Even where, how much, if you drain a placenta, how much blood can you actually get out of it? And it's a significant amount.
Wow.
Then you can separate out the stem cells, and then you have a pure stem cell population. And boy, those are the best. That's the cream of the crop there.
I was reading something recently. Close your ears if you don't want to hear this. A little bit gross, but I know animals will actually eat the placenta, right?
Yes.
From their when they have
Yes.
when they have a birth,
You
and
bet.
there is a significant number of humans that do that as well.
Mm-hmm.
People will get together in a club, and when a baby's born, I mean it's kind of gross to even be. Shouldn't even have brought it up, but apparently it's there's a belief that that's life extending and very important for health.
Right. I would imagine primitive man ate their placentas.
Yeah.
And that would only make sense. They're very rich in nutrition, obviously, because you've just created a baby
Yeah.
based on what that placenta can produce. And it's rich in hormones, it's rich in the stem cells, and just good nutrition. And
Yeah.
that was probably hard to find.
Yeah.
And so not eating the placenta, we wonder why we don't. I mean, I would say, why don't we? Get it fresh and, and
Throw a little chocolate flavoring in there.
yeah. I mean, I know it's a gross thought for our culture, but and
Yeah.
in other cultures they do it, and within our culture, I know there are groups of folks who do it.
Yeah. Well, let's just sort of switch subjects for a minute, and let's talk about Dr. J, the person. And you are living here in Las Vegas, in Boulder City, right?
That's correct.
Great place, right next to the Hoover Dam.
Yep, love it.
Yeah.
I'm an Oregonian, and I have web feet to
Yeah.
prove that. I spent 24 years there year round, raised my family, and we raised our families. I'm in my second marriage. But 8 years ago, I decided that was enough of the rain in the winter, and so I came to Boulder City and been here every winter since. And I'm here about 8 months out of the year.
You spend the summers in Oregon.
Yeah, I go back there because it's still a pretty amazing place.
It's pretty
to be.
amazing in the summer, yeah.
Yeah,
Yeah, but you get a little rust on your head when you're there in the winter, right?
boy, you do. Yeah, moss grows everywhere.
It does. That's right. So I had a chance to meet your lovely bride, and tell us about her.
Well, Erin Lohman. Well, actually, this goes back to my career change. 20 years ago, as I mentioned, I was working with the Red Cross, decided to see patients, and wasn't sure how all that was going to play out, so it was a risk. I stepped off the curb, as I say. But I got involved with a clinic where they were treating multiple sclerosis with diet. Roy Swank, in fact, Roy Swank has written a book, and I worked with him at his clinic for a year. He was 91 years old,
Wow.
and I got the idea that you could affect a chronic disease, a chronic debilitating disease, at least that's the thought. I don't think of multiple sclerosis that way. After seeing 400 patients and seeing what he could do with just diet. Just a low saturated fat diet and cod liver oil. Now, what Dr. Swank didn't understand that I understand now is that vitamin D is in that cod liver oil, and that's critical for multiple sclerosis patients. So anybody listening who has multiple sclerosis, vitamin D is critical for you. You want to take a look at that very seriously. But I realized that we can impact our health by a lifestyle change. So his clinic closed in about a year, and I decided to look into this and with more depth. And I went to the National College of Naturopathic Medicine in Portland, Oregon. And I asked them if I could follow them around and learn something from them. And well, it turned out they needed an instructor in pathology. So they hired me to teach pathology for 6 months. But while I was there, I went to all their clinics and I read their books, and I realized that I knew very little about health as an allopathically trained physician, board certified, licensed to do all this stuff, but I was not aware of the options for wellness. And it starts again with diet and intestinal health and so on, which the naturopaths knew. So I learned so much from them. Within the 6 months, I started my own clinic.
Well,
And I started doing, applying their concepts. And in that process, I ended up meeting Erin Lohman, a naturopathic physician, Dr. Lohman, my wife. And she came into my clinic, and we started, basically started the clinic together. I happened to have the doors open, but she really made it hum. And so she came in, and we started seeing patients in an integrative fashion, which was very popular. and should be, and I will continue. I think it will continue to be popular to seek that holistic, complementary, alternative world where you look at all of it. You know, I don't throw out all of my allopathic training, and it was been helpful for me.
Yeah.
But I rarely use a pharmaceutical, and she taught me that. The school taught me that, and so we had our clinic in Portland, Oregon for 10 years, and then we started a laboratory, and then it's called Labrix Clinical Services, where we were doing saliva testing and urinary neurotransmitter testing, and that was another great opportunity.
Now, that lab got pretty famous, as I understand. So a lot of people know about that.
Well, it was successful, and we were very pleased with that success, and we feel like we've helped a lot of people, and there are a lot of practitioners who use our testing, and that's where we end up teaching. Dr. Lohman teaches, and I speak as well, and we go to various conferences and educate.
What does it feel like to know that you've saved someone's life, or you've totally turned their life around?
Nothing like
you ever
it.
think about that?
Nothing like it. Nothing like it. And I wouldn't have gotten that in allopathic medicine, even if I'd been on the front lines of allopathic medicine, because you rarely see that.
Yeah.
Because what you're doing there, and it's unfortunate, but you're taking a chronic disease and making it more chronic. The idea is you just keep, whatever the next drug is, you treat with that, and then there's side effects, and then you got to bring in some other things, and so you're never really getting to the bottom of it, the core issue of the condition. And so that's unfortunate for where we are in medicine now. But we're looking for, in the world I work in now, and Dr. Lohman works in, and some others now are getting more interested in this. In fact, there are organizations now that are teaching physicians thousands at a time now. I mean, this is exploding, this idea that we're going to be able to get to the core issues and treat those without drugs. The key there to the audience here is that it's not a prescription, and it's not a pill, and it's not going to be quick. It's going to require effort. There's going to be lifestyle changes that are going to be required for you to do that. Just changing your diet can do it. It can make a tremendous change in your health.
So let's talk about that in the couple minutes we have left here. What do you recommend for breakfast, lunch, and dinner? What kind of diet should we have?
That gets complicated because you start laying out diets like that, but it's simple, really. And I would encourage your readers to take a look at the China study by T. Colin Campbell. It's a book where his study will never be reproduced. So he went to China for 10 years, a prospective study, and China monitors their diseases very carefully, and so you could go to areas where more cancer, etc., and look at what people ate.
Yeah.
And what he discovered, it's very simple: plant-based. So eat your veggies, whole foods. So not processed foods, whole foods, and low fat. And he doesn't even say, although he's a vegan now, from what I understand, you don't have to be a vegan to follow that. Just plant-based, whole food, low fat. That's all. And so, when people say, well, what do I eat then? And I said, well, you can go to any bookstore, and there are hundreds of books on how to cook vegetables. Go to an Indian restaurant, a Mediterranean restaurant. And there are a number of cultures that have already adapted this and understand that, and they have recipes that are delicious.
Yeah, I wish we had another hour because this is so fascinating. But we'll have to have you. We'll have you and your wife come back sometime, and we can talk a little more because it's just an amazing thing.
Yeah, well, she'll be a good guest for you. She has a lot to contribute.
Absolutely.
Yeah.
Well, Dr. J, it has just been an honor. I feel smarter just sitting next to you. I feel like some of that knowledge is just, but it'll go in one ear and out the other in my head. But just to know you has just been a real pleasure. So thanks for joining us, and we'll look forward to next time.
Well, it's my pleasure. I appreciate the opportunity.
Well,
Thank you.
Thank you. And we'll see you next week, same time, same station. Bye-bye, everybody.